Hello and welcome everyone. Today's presentation is on the 2024 guidelines on how to use albumin in the ICU. The first is the recommendation regarding critically ill adult patients. This excludes those with thermal injury and ARDS. Intravenous albumin is not recommended as a first-line volume replacement or to increase serum albumin levels. This is a conditional recommendation with moderate certainty of evidence. In patients with thermal injury or ARDS, intravenous albumin is not recommended for volume replacement or to increase serum albumin levels. For use of intravenous albumin with diuretics for extravascular fluid removal, this is not recommended, again very low certainty of evidence. Now these recommendations are based on these studies. 16 out of 19 systematic reviews analyzed covered a broad critical care patient population. 3 reviews were excluded due to their focused area. Now in 2019, systematic review found no mortality benefit of using albumin over crystalloids. 2018 Cochrane review again found no difference in terms of mortality or renal replacement therapy in ICUs with crystalloid versus albumin. SAFE trial, no difference in outcome in 28-day mortality with 4% albumin versus normal saline for fluid resuscitation. A 2015 systematic review on traumatic injury, higher mortality with albumin with specific concern for traumatic brain injury subgroup. A 2020 systematic review on sepsis, albumin was not superior to crystalloid for mortality or acute kidney injury. Albios trial, no improvement in 28-day mortality or other outcomes with albumin in septic patients. Review on albumin and thermal injury, no impact on renal replacement or mortality. 4 RCTs are there. Regarding albumin and diuretics in mechanically ventilated patients, reduces hypotensive episodes but no impact on mechanical ventilation duration or mortality. Impact of albumin in ARDS with furosemide, no difference in mortality or in facilitating fluid removal in hypovolemia. Various studies and patient numbers. Now, what is the rationale behind the recommendations based on these studies? Now, the lack of supportive evidence for the use of albumin in reducing mortality, the need for renal replacement therapy, or other crucial outcomes have led to the conditional recommendations. But we must keep in mind that the level of evidence is very low in most of the cases. Despite the Surviving Sepsis Campaign guidelines, a weak recommendation for albumin in certain septic cases, the overall evidence does not strongly support the albumin use over crystalloids, mainly due to the cost, risk, and lack of benefit in the RCTs. One thing that we must keep in mind that most of the RCTs have looked at mortality as a impact, but usually the outcome is not mortality, as we are looking in other certain outcomes like early removal of vasopressors, less requirement of vasopressors, or improvement in the oxygenase parameter if you are giving albumin with diuretics in ARDS. So keeping all these things in mind, you have to use it specifically, especially in a critically ill patients with ARDS or septic shock, but preferably in a research background. Or if you are not using in a research background, you want to use it in your clinical practice, then maybe you look at outcomes which is other than mortality, like if my patient is getting off vasopressors or my oxygenation is improving. If these parameters are going, then you may use albumin in septic patients or ARDS patients. The next is critically ill pediatric population with severe infection. The recommendation is for pediatric with severe infection with hypoperfusion, albumin is not recommended to reduce mortality. The evidence summary is a single systematic review identified 3 RCTs comparing albumin with crystalloid, primarily in African countries with severe malaria or febrile illness with impaired perfusion. The enrolled 61 children with severe malaria showed no mortality difference between albumin and crystalloids. 250 children of severe malaria showed improved mortality with albumin compared to crystalloids. Finally, we had the FEAST trial, which had 3,141 patients. And comparing saline bolus with 5% albumin and no bolus, the trial was stopped early due to excess mortality in both the albumin and saline bolus groups compared to no bolus. No mortality difference was observed between albumin and crystalloid arm at 48 hours, but excessive mortality was seen in bolus groups at 28 days. So what is the rationale? The FEAST trial is a large, well-designed, significantly influenced the recommendations against using albumin in patient population, primarily due to observed excess mortality with bolus administrations. Now, this suggests a cautious approach to fluid resuscitation strategy in critically ill with severe infection, particularly in the setting similar to those with included trials. So if it is a pediatric population coming with severe malaria or severe infection, then any kind of a fluid bolus is not recommended. It is better to check and give fluid, not a bolus fluid in all cases. So it has to be individualized, and even if you're individualizing, you can still give crystalloids rather than going for albumin resuscitation. The next is for neonates in critical care. For preterm neonates, that is less than 26 weeks with low serum albumin level and respiratory distress, intravenous albumin is not suggested to improve the respiratory function. This is again based on low certainty of evidence. In preterm, that is less than 32 or less than 150 gram with or without hypoperfusion, intravenous albumin is not suggested for volume resuscitation. This is again very low quality of evidence. Regarding what evidence is available, the use of albumin in preterm neonates, a Cochrane systematic review included 2 RCTs with 64 preterm neonates, finding no significant difference in the mortality. Early volume expansion, another Cochrane review of RCT did not find significant difference in mortality when comparing 5% albumin to normal saline, 20% albumin to no treatment in normotensive, and plasma to albumin in hypotensive individuals. The studies varied in indication for the intravenous fluid administration and showed no benefit in albumin over other fluids. Recent RCT on term infants found no difference in outcome when comparing 5% albumin with normal saline in terms of dehydration, metabolic acidosis, or diarrhea. Now, the rationale behind the recommendation is the recommendation are based on very few RCTs with small sample size, limiting the ability to draw definitive conclusions regarding the efficacy of the albumin. Now, the cost of albumin and the absence of trials assessing the potential harm are significant considering the risks available. Indirect evidence from adult and pediatric support the cautious use of albumin in the neonatal care as well. Now, coming to the use in kidney replacement therapy, the recommendation for intravenous albumin use is in patients undergoing renal replacement therapy, IV albumin is not suggested for prevention or treatment of intradialytic hypotension or for improving ultrafiltration. Again, based on low quality of evidence, the evidence summary is a Cochrane review where the investigated albumin versus alternative strategy for intradialytic hypotension. A single randomized crossover trial of 45 patients comparing 5% to normal saline showed no difference in target ultrafiltration achieved or other clinical outcomes. Now, the trials are 2 small crossover trials of albumin with gelatin and albumin saline with very small populations suggesting better blood maintenance with albumin, but no improvement in ultrafiltration or other clinical outcomes. A 2021 randomized crossover trial of 65 patients indicated improvement in hypertension, lowest intradialytic systolic pressure, and ultrafiltration with 25% albumin compared to saline. Now, regarding the rationale, the intradialytic hypertension is common in renal replacement therapy and it is associated with increased mortality and morbidity. The high cost of albumin versus lack of evidence supporting its superiority over less expensive fluids is the reason of the recommendation. The use of alternative strategies like midodrine, high dialysate calcium, lower dialysate temperature, individualized filtration rates are explored options to mitigate the hypotension. To better understand intradialytic hypotension, pathophysiology, evaluating albumin's effectiveness in preventing the hypotension or improved ultrafiltration and improving the patient outcome needs to be done. So as far as the renal replacement therapy and the intradialytic hypotension is concerned, there is a very small evidence that albumin can be helpful, but it is based on very small group of patients. So if you are using albumin, then you have to use it cautiously if you have no cost implications. But if there are cost implications, then you may try the other therapies. Again, even the alternative therapies are not yet proven. So overall, the evidence level is very low, but as of now, using it outside a research setup is not really recommended in clinical practice. Regarding the use in cardiac and vascular surgeries. Now, in adult patient undergoing cardiovascular surgery, intravenous albumin is not suggested for priming the cardiovascular bypass circuit or the volume replacement. Again, a moderate certainty of evidence. For pediatric undergoing similar setup, then it is not suggested to prime with albumin. Again, a very low certainty of evidence. Regarding the summary of the evidence that is found, there are a lot of studies, 43 RCTs with 3,862 patients comparing albumin with gelatin and crystalloids, the priming of cardiopulmonary bypass circuit. Studies show no major improvement. The outcomes show no major difference in terms of mortality, in terms of renal failure, even in terms of blood loss, ICU stay, or other component use. The fluid balance is lower with albumin than with alternative solutions. So that is something which must be kept in mind. If you are really concerned about the fluid balance of the patient and trying to keep the patient negative, then you may consider albumin as a therapy in this particular setup. The largest trial, that is the ALBIC trial, compared 4% with ringal lactate with 1,386 and found higher rates of bleeding, re-sternotomy and infection with albumin. Now, the rationale of recommendation, the prevalent use of albumin in cardiovascular surgery lacks substantial evidence in its efficacy in improving the patient outcomes. The ALBIC trial, the largest to date, showed increased morbidity with albumin compared to ringal lactate. Now, the impact of high-risk cardiac surgery is under investigation with a similar trial ongoing. But the rationale behind why these findings were seen in albumin is not yet known. Finally, the most important use, that is the use in cirrhosis, the clinical recommendation for patients with cirrhosis. Now, for cirrhosis, large volume paracentesis, that is more than 5 liters, suggested to prevent paracentesis-induced circulatory dysfunction. It can be used. It is a conditional recommendation based on very low quality of evidence. Regarding spontaneous bacterial peritonitis, it is suggested to reduce mortality, but again based on low certainty of evidence. For extraperitoneal infection, not suggested to reduce mortality or renal failure. For decompensated cirrhosis with hypoalbuminemia, repeated intravenous albumin is not suggested to reduce infection, renal dysfunction, or death. For outpatients with uncomplicated ascites despite diuretic, not routinely suggested to reduce complications. So regarding the evidence summary that we have, large volume paracentesis, albumin superior to other volume expanders. A 2019 Cochrane review of 27 RCTs with 1,500 patients showed mixed results in terms of mortality, renal impairment, and recurrent ascites. Regarding spontaneous bacterial peritonitis, albumin reduced the rate of renal impairment and mortality in systematic review and major RCTs. However, the exact benefit regarding the dose and the patient selections still remains unclear. Regarding extraperitoneal infection, no benefit is seen in albumin in terms of mortality or renal failure. Decompensated cirrhosis, no benefit in targeting albumin more than 3. Outpatient with uncomplicated cirrhosis, systematic review found no benefit. So the rationale of evidence, paracentesis, continued use of albumin for large volume paracentesis is suggested based on its effectiveness in preventing circulatory dysfunction, but very low quality of evidence. And spontaneous bacterial peritonitis, again a conditional recommendation to use albumin because it has shown to improve the mortality and renal impairment. Extraperitoneal and decompensated cirrhosis, no recommendations. Outpatients, not recommended. So overall, first determine why are you giving albumin, what is your patient background, whether the patient is septic, whether the patient is cirrhotic, renal failure, what is the background, and what is the outcome that you're looking for using the albumin. Then in those cases, you can use albumin. So as of now, there is a very few limitations where albumin has been conclusively shown to be used, but then the patient selection is a major issue. We cannot still say that albumin doesn't have a role because it is a very vital protein inside the body, and it is a major protein which does much more activities apart from just being a oncotic agent or transporting material. It has various functions. So albumin could be of benefit in various patient populations. So, but then the patient selection is important. Our outcome selection is important. Only then we can find the correct use as of now. Most of the evidence is based on very poor quality of evidence. Thank you for your patience till now.